You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for August 17th, 2018. This week, I'm talking about screening athletes for heart disease, female doctors in survival from myocardial infarction, complications from AF ablation, the burden of chronic kidney disease, and a settlement in Texas relating to rosuvastatin. So first up is screening in young athletes. One of the most prestigious sports cardiology centers, St. George's, University of London, recently published the most extensive survey of screening for heart disease in young athletes. They screened over 11,000 16 to 17-year-olds who were picked to play in the English Football Association. The kids that were mostly male all had exams, ECGs, and echoes. New England Journal of Medicine published these important findings. And of the 11,000 kids, 42 of them, 0.38%, were found to have heart disease that was capable of causing sudden cardiac death, though half of these were WPW cases. Significant heart disease that's not typically associated with sudden cardiac death was found in 2%, or 225 of these kids, and this included valvular disease and septal defects. The overall incidence of sudden death they reported was just 6.8 per 100,000 athletes, and during the 20-year period, 23 kids died, and only 8 of them from cardiac causes. Remarkably, all of the 8 cardiac deaths had autopsies, and 7 of the 8 had cardiomyopathy. But here is the key observation, and sit down for this. 6 of the 8 kids who died had a totally normal screen. They had normal ECGs and echoes, and the authors of the paper actually had independent reviewers come and look at these persons' ECGs and echoes, and they confirmed that they were indeed normal. And the costs were staggering. They used prices in the UK. Certainly, it's much more pricey in the US. The screening program cost beyond $4 million. Now, these findings reach New England Journal because they're important. The first point is that disease incidence in this age group is rare, which of course impacts the capabilities of screening. Remember, if the incidence of disease is less than 0.5%, that means 99.5% of millions of young people don't have the disease. And that fact sets the stage for massive miss and overdiagnosis because ECGs and echoes are nowhere near 100% specificity. Now, most striking here in this case is that the best group in the world doing the most sophisticated testing that is feasible, ECGs and echoes, did not identify disease in 6 of the 8 kids who died from cardiac causes. So this problem is the opposite of specificity, or sensitivity of the screening test is even lacking. Now, this is not a knock on the researchers. Rather, it speaks to the difficulty of finding disease. I mean, perhaps these kids were too young to have manifested cardiomyopathy. So if you add the massive cost to the above-noted specificity and sensitivity problems, I argue in a features piece that I'll link here that we should surely not mandate screening and even consider not screening these kids at all. Now, unless something new comes along, perhaps a gene risk score or a faster, less expensive MRI, for instance, the use of standard screening of young people stands to do far more harm than good. Though it's less satisfying than prevention, I think the best way to prevent kids from dying in sports is to have more AEDs available and more community training on CPR. Second topic is complications from atrial fib and atrial flutter ablation. Now, one of the main drivers in the decision to ablate AFib or aflutter is, in my opinion, procedural harm. AFib is a serious condition, no doubt, but the downside risks, the harms from ablation, can be far worse. You could say the downside risk of AF ablation is asymmetric. Now, that's why a German database registry study published in the European Heart Journal is so important. Now, unlike single-center cohort studies and RCTs, which enrolls select patients from specialized centers. This analysis studied what is happening in the real world of AF ablation in Germany. All German centers are required to report on DRGs and outcomes. This study, therefore, avoids the common problem with voluntary registries, namely that patients get entered into these registries at the discretion of the doctors. Ablation in Germany is also similar to the U.S. in that it is well reimbursed, and therefore it gets done at many different hospitals, and some of them low-volume centers. This massive analysis included more than 33,000 cases, 19,000 of which were left atrial ablations. And unlike previous studies in the U.S., which has also chronicled high rates of complications, in Germany, all AF ablations are done as inpatients, and this means the authors captured most, if not all, AF ablation. The authors separated right atrial ablations for flutter and left atrial ablations for AFib, and the main findings were that complications rates were strikingly high, in the range of 11 to 13% overall, and major complications of like 3.8 to 7%. I don't think any of us quote those kinds of statistics with patients before AF ablation. At least I don't. Notably, some of the serious complications, pneumonia, in-hospital death, and AV block, were actually higher in the much easier right atrial flutter ablation. Now, this is most likely due to the fact that flutter ablation is often offered to patients with greater comorbidities. Now, when I tweeted that this study raised serious concerns, many of my colleagues downplayed the high rates of complications, and one explanation was that the German coding system favored upcoding of complications. This claim the authors mentioned in the discussion but felt was unlikely because they say that at least 15 to 20% of the cases are audited and systematic upcoding would likely have been discovered. Another way these high rates were dismissed was this line that I heard or saw on Twitter: "Our complication rate is much lower." Now, I'm not sure the estimates in this study are falsely elevated, really. For instance, one can argue they might have underestimated serious complications because many complications occur later, not during the hospitalization. For instance, esophageal injury, pulmonary vein stenosis, some pneumonias, tamponade occur after hospital discharge and wouldn't have been counted in this study. We should also pay attention to the sub-analyses they did in the study, and here showing that complications rates were higher at low-volume centers. This doesn't mean all low-volume centers do substandard work, but we surely don't need ablation centers in every small satellite hospital. In my mind, these findings strengthen my preferred approach to be conservative with AF ablation. The first step is to extract fear. So many patients with AFib are fearful. You inform and educate the patient. Then correct putative causes of AFib like obesity and sleep apnea and excess alcohol. Then perhaps try a trial of antiarrhythmic drugs and then ablation. This way, if an ablation complication were to occur, there is a lot less regret for having not done all that could have been done with less risky means. Third topic today is gender and the doctor-patient relationship. So the press release from one of science's most prestigious journals, the Proceedings of the National Academy of Sciences, or PNAS, suggested that women with suspected heart attacks should seek female emergency medicine doctors. This because a provocative analysis of administrative data from Florida hospitals found a distinct asymmetry in MI mortality based on the doctor-patient gender concordance in the emergency department. Specifically, female patients were less likely to survive an acute MI when treated by a male physician. Now, I took this quote from the second line of the discussion section of the paper. Quote, "Most physicians are male, and male physicians appear to have trouble treating female patients. The fact that gender concordance correlates with whether a patient survives a heart attack has implications for theory and practice." Now, not surprisingly, and similar to an earlier paper it published in JAMA Internal Medicine last year, which found that lower hospital mortality for patients treated by female hospitalists, mainstream media has been all over this story. I read some of these stories, and most of them leap from association to causation and then speculate on reasons for the discordance. For instance, female docs better understand the atypical nature of cardiac symptoms in female patients, or female doctors have more empathy than men, or female patients may feel more comfortable advocating for themselves with female docs. Now, my comments on this are tough. I struggled with this. Since I am male, I suppose some will discount my analysis. But there are many problems with this study, and I'm sorry. First, even if these findings were true, the delta here is a 5% reduction of an 11% mortality in absolute terms. That is about 6 in 1,000. So a 0.6% reduction in mortality in an observational study is simply not robust. Stanford meta-researcher John Ioannidis has taught us that small effect sizes should be viewed with caution. Then I ask, in this era of troponin studies and emergency cath lab activation, how much impact does the initial encounter with the emergency medicine doc have on mortality? For instance, in my hospital, in many cases nowadays, the cath lab is activated from the ambulance before the patient is even seen by a physician. The authors themselves noted the fact that many things happen to a patient with an MI from first visit in the emergency room to death from myocardial infarction. Now, please don't mistake my critique of the methods of this analysis as a slight to women physicians. My hospital and my cardiology group have many women docs. They are skilled and they have rightly earned the respect of everyone. And I also advocate for saner policies that would encourage and enable more women to pursue careers in cardiology. But in the same way, we should be skeptical and critical of blueberry and chocolate studies. We must keep our guard up on over-interpretation of observational retrospective studies from claims like this one. Next topic is the burden of chronic kidney disease. Insidious is the modifier that comes to mind, proceeding in a gradual and subtle way, but with harmful effects. And this is how I would describe the normalization of the crisis in obesity, diabetes, hypertension, immobility. In the U.S., obesity is so common, it's hardly notable. At many hospitals, staff are forced to take modules on how to talk about obesity so as not to be unkind. And it's gotten so bad that even in hospitals, institutions of health, no one is disturbed by the fact that bake sales are used to raise money for the American Heart Association. Now, one of the ways this insidious march of unhealth will shorten our lives is through kidney disease. Authors from St. Louis used the global burden of disease study data to describe the changes in burden of chronic kidney disease from 1990 to 2016. Kidney International published their paper. CKD incidence, prevalence, death, and disability-adjusted life years all increased substantially over this period. The editorialists from the paper point out that the evidence is now overwhelming that chronic kidney disease is vastly more common than was appreciated 20 years ago. And its impact on adverse health is not limited to only end-stage renal disease. Not unexpectedly, globally, the authors found that more of the burden of chronic kidney disease was in lower-income countries, and they also noted an inverse relationship between CKD disability and access to quality health care. But the news wasn't great for high-income countries like the U.S., though it's clear that one driver of increased burden of chronic kidney disease in higher income countries is that people live longer, so aging. Another finding from this analysis was that disability due to CKD actually increased in high-income geographies such as North America, where the increased burden of diabetes-induced kidney disease outpaced the burden expected by demographic expansion. The authors noted opportunities for improvement in both situations. Obviously, for lower-income countries, it is better access to care. And for us in the U.S., efforts to reduce the burden of diabetes and other risk factors would surely reduce the burden of kidney disease. And once again, I see physicians as leaders in this reversal, and we must first resist the normalization of unhealth. Last topic today is about AstraZeneca's settlement in Texas. Now, AstraZeneca has agreed to pay $110 million to settle two lawsuits brought by the state of Texas for fraudulent marketing of a psych drug and rosuvastatin. And I mention this settlement because it stimulated me to look back at a pivotal trial of rosuvastatin, the Jupiter trial. In the case in Texas, one of the three claims made by whistleblowers who were former employees from the company alleged that rosuvastatin could reduce the risk of death. Now, okay, I thought, what gives? I thought Jupiter showed this. And so for review, Jupiter was a RCT in 2008 of apparently healthy people with increased CRP levels in which rosuvastatin was tested against placebo. The primary endpoint was a composite of MI, stroke, revascularization, hospitalization for unstable angina, or death from cardiovascular causes. Cardiovascular causes is the key feature here. Rosuvastatin did indeed reduce the primary endpoint, 0.77 versus 1.36 per 100 person years of follow-up. But here's the problem. The authors reported all the components of the primary endpoint except death from CV causes. It's just absent from Table 3. The paragraphs in the results and discussion sections don't mention it. Instead, the authors reported death from any cause, which was 20% lower, p-value 0.02. And they made note of this in the discussion. But in the adverse events table, the authors also report death from cancer as significantly lower in the rosuvastatin group, 35 versus 58. But everyone agrees statins don't reduce death from cancer. Now, it turns out that three other authors, including Rod Hayward from University of Michigan, wrote in a letter to the editor that by their calculations, CV death was not significantly reduced, a finding at odds, they said, with previous statin trials. The Jupiter authors wrote back and they countered that these numbers were not accurate and that many out-of-hospital deaths from CV causes were classified as non-CV deaths due to strict confirmation criteria in the trial. Now, by the way, I went back to look at HOPE-3, another big primary prevention trial of rosuvastatin, and the authors of HOPE-3 did indeed report CV death, and it was not significantly reduced in HOPE-3 either. So the issue here is if reps at the time pushed rosuvastatin for reduction of death, that would be problematic because how could a statin reduce death if it did not reduce cardiovascular death? Now, I did not previously know about this controversy over Jupiter, and you can see the problem if the more expensive rosuvastatin was pushed onto the Medicaid formulary in Texas and may have been no better than atorvastatin or perhaps inferior, that would be a problem. Now, maybe my comments here will generate some comments from those of you who know more about this story than I do. The bottom line is this, and it speaks to the fact that we all have to do our own due diligence when it comes to critical appraisal. You would never get this sort of nuance if you just listened to drug reps over lunch at the office. So that's it for This Week in Cardiology. I'm grateful that you listened. Thank you. This is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.